Okay, let's dive right into this Step 2 CK Next Best Step explainer of hypertensive disorders and diabetes in pregnancy. We're getting straight to the high-yield stuff, starting off with the classification of hypertensive disorders. The 20-week gestation mark is absolutely crucial here. It's your diagnostic anchor. This single timeline cutoff literally dictates your entire logic for differentiating chronic hypertension from new onset conditions like gestational hypertension and preeclampsia. And keep in mind, if a patient with baseline chronic hypertension suddenly develops new or worsening proteinuria, sudden worsening hypertension, or signs of end organ damage, you're now dealing with chronic hypertension with superimposed preeclampsia. So, thinking about the exam logic, it's pretty straightforward. An elevated blood pressure, meaning a systolic of 140 or a diastolic of 90 or higher, presenting before 20 weeks is definitively chronic hypertension. Done deal. But if you see new onset elevated blood pressure at or after 20 weeks, you've got to immediately check for proteinuria or signs of end organ damage. That's the only way you'll be able to differentiate gestational hypertension from preeclampsia.
Making that preeclampsia diagnosis requires some very rigid proteinuria criteria. We're talking either 300 milligrams per day on a 24-hour collection or a protein-to-creatinine ratio of 0.3 or higher, period. And remember that initial elevated blood pressure, it has to be confirmed. You need 2 separate measurements taken at least 4 hours apart to lock it in.
Under the hood, preeclampsia is driven by abnormal placentation. This causes a whole cascade: placental ischemia, endothelial dysfunction, vasospasm, capillary leak, and microthrombi. So who's at risk? Patients with a history of prior preeclampsia, chronic kidney disease, chronic hypertension, diabetes, multiple gestation, autoimmune disease, obesity, nulliparity, or advanced maternal age. If they fall into these high-risk buckets, your preventative next best step is initiating low-dose aspirin, starting right around 12 weeks gestation.
Now, if preeclampsia does develop, you have to actively hunt for severe features. These fundamentally shift your management strategy, so you need to memorize these exact lab value thresholds for the test. Severe range blood pressure is a systolic of 160 or a diastolic of 110. Other red flags: platelets dropping below 100,000, creatinine jumping above 1.1 or doubling from baseline, transaminases hitting twice the normal limit, pulmonary edema, persistent headaches, visual symptoms, and right upper quadrant or epigastric pain.
Let's talk about pulmonary edema for a second, because it's a severe, life-threatening complication. Here's the mechanism. Generalized arterial vasospasm leads to a massive increase in systemic vascular resistance. To overcome that hypertension, the heart has to pump against a really high afterload. This forces up pulmonary capillary pressure, driving fluid straight into the lungs. Clinically, this presents as dyspnea, hypoxia, and crackles.
When you see those severe features, you're immediately going down 2 acute treatment pathways. First, you have to rapidly lower that severe blood pressure to decrease the risk of hemorrhagic or ischemic stroke. Second, you need to get magnesium sulfate on board to prevent eclamptic seizures.
For acute blood pressure control, your first-line agents are IV labetalol, oral nifedipine, or IV hydralazine. But here's where they try to trick you on the exam. Watch out for these classic gotchas. You absolutely must avoid labetalol if the patient has a history of asthma or bradycardia. And you want to avoid oral nifedipine if the patient has severe nausea or is actively vomiting. Obviously, just utilize an IV option instead.
Shifting gears to eclampsia. This occurs when preeclampsia is complicated by new-onset tonic-clonic seizures, which are typically followed by a post-ectal phase. If you happen to get a head CT for an eclamptic patient, the classic diagnostic finding you're looking for is bilateral frontal lobe edema.
Managing that magnesium sulfate requires some really close monitoring. We're checking deep tendon reflexes, respiratory rate, and urine output. Why urine output? Well, magnesium is exclusively excreted by the kidneys, so poor renal function dramatically increases the risk of toxicity, which can lead to a loss of reflexes, respiratory paralysis, and even cardiac arrest. If you see signs of toxicity, treat it immediately with an IV calcium gluconate bolus to reverse it.
There's one massive exception you need to know. Magnesium sulfate can actually worsen myasthenia gravis and trigger a full-blown myasthenic crisis. So the crucial point is, magnesium sulfate is strictly contraindicated in myasthenia gravis patients. The correct alternative for seizure prophylaxis in this specific scenario? Valproic acid.
Let's clarify the definitive management rules for delivery timing. If the patient is under 37 weeks and completely stable with no severe features, you manage them expectantly with very close maternal and fetal monitoring. Once they hit 37 weeks, deliver. But if they develop severe features, that generally requires delivery at 34 weeks or later, or frankly, immediately if either maternal or fetal status deteriorates.
Next up is HELP syndrome, a severe manifestation of preeclampsia. You're looking for a very distinct diagnostic triad here: microangiopathic hemolytic anemia, elevated liver enzymes, and a low platelet count. Keep in mind, these patients very often present with nausea, vomiting, and really noticeable right upper quadrant or epigastric pain.
For HELP syndrome, you stabilize the patient with magnesium for seizure prophylaxis and antihypertensives. But make no mistake, definitive treatment absolutely requires delivery at 34 weeks or sooner if status worsens. Real quick before we wrap, don't forget the high yields for diabetes in pregnancy. Gestational diabetes is driven by human placenta lactinogen, causing insulin resistance. You screen at 24 to 28 weeks with a 1-hour, 50-gram glucose challenge. If it's abnormal, confirm it with a 3-hour, 100-gram test. High-risk patients get screened at their first prenatal visit and again at 24 to 28 weeks if negative. First-line treatment is diet and exercise. If targets aren't met, that's fasting below 95, 1-hour postprandial below 140, and 2-hour below 120, then you use insulin. And lastly, pregestational diabetes in the first trimester increases the risk of congenital anomalies and miscarriage, while later fetal hyperglycemia causes hyperinsulinemia, macrosomia, shoulder dystocia, neonatal hypoglycemia, polycythemia, hypocalcemia, hypertrophic cardiomyopathy, and respiratory distress syndrome. Postpartum, always remember to rescreen gestational diabetes patients at 6 to 12 weeks with a 75-gram test.